Good morning, everyone, and welcome to our fifth webinar on the role of inflammation in psychosis. My name is Giuliano Tomei, and together with my colleagues Isobel and Danielle Smith, we'll be chairing today's webinar. Before we hand over to today's presenter, I would like to give a few details about the structure of this webinar. So we will have a 20 minutes presentation, which will then be followed by 10 minutes for question and answers. As you might have noticed, attendees to the webinar are currently muted to avoid background noise, so you're invited to use Zoom's chat to send all your questions during the presentation. Should we not manage to answer all the questions within the allotted time for today, we will then copy them into a document which we will distribute by email in a few days' time. Please note that this webinar, as for the others, is being recorded and will be added on YouTube, and then it will be freely available for you and your colleagues to view again and share. So having said that, I'm pleased to introduce today's speaker, Professor Michael Zandi, consultant neurologist at the National Hospital for Neurology and Neurosurgery, and honorary associate professor at the University College London, which will give a presentation titled Encephalitis and Psychosis, Lessons from Encephalitis Lethargica to COVID-19. So Mike, over to you. Thank you.
Yeah, thanks so much. It's a real pleasure to be here and to speak to this group. And I thought what I'd do, because you've got some very good speakers talking about antibody-associated psychosis and other aspects of immunopsychiatry related to the PEEP study, the prevalence of pathogenic antibodies and psychosis study that we're all involved with, but also the SINAPPS trial, this study of immunotherapy in individuals who have antibodies and relatively isolated psychosis, in which it's unclear whether they have encephalitis and should have immunotherapy, or whether the antibody is not disease causing. So I'm assuming a lot of background knowledge, and you've had the excellent Thomas Kabir, for example, talking about patient and public involvement and all the issues. So I was going to talk really from my own experience as a neurologist who's been working with psychiatrists now for about 13 or 14 years, and to really give a little bit more of the background of how we started this work, and to put it into the context of the of 100 years really of similar themes. And I think we're seeing now, with the emergence of COVID, we have seen people with psychosis and encephalitis, albeit rare, and we know that there's been encephalitis and psychosis 100 years ago with the outbreak of Encephalitis lethargica. And I think there are lessons there that are useful to us now as we're trying to move forward and look at antibody-associated psychosis. So 100 years ago, and thanks for your help with the slides, 100 years ago there was this big outbreak of Encephalitis lethargica, most famously portrayed in the book Awakenings and the film. So Oliver Sacks awakening up people who had been locked in their bodies for decades, having had this curious illness, and some of those people had Parkinsonism or signs of rigidity and slowness, and that part could be treated with levodopa, and that was done by Oliver Sacks in the 60s. And this was a curious illness, and we can't study now the brains or the people who had this illness. We still don't know if it was a virus or the immune system affecting the brain, but it's got great similarities to NMDA receptor encephalitis, and also some aspects of COVID-19 neurology. It's very important to say we're not seeing really, or we don't think we're seeing encephalitis lethargica now, but it's a big area of research. Encephalitis lethargica came around the same time as the large 1918 pandemic, the influenza pandemic, which killed, we think, up to 50 to 100 million people in the world in 1918. Now, encephalitis lethargica, the first cases of what was probably encephalitis lethargica, which was the sleeping sickness, drowsiness, coma, brainstem signs, problems with eye movements, hiccups, lots of psychopathology. First cases were probably described in 1915, so antedating the influenza pandemic. But it's unclear really what those cases were. The large bulk of cases coming on in the late 1910s, but also still occurring in the 1920s and 30s. And often individuals will have had a febrile illness or some flu-like syndrome and then have a decline, a neurological decline, sometimes months or years later. And it's very hard now in retrospect to be really certain about causation here. And that's still a problem that affects us in autoimmune psychosis, is trying to really determine whether the presence of, for example, an antibody is causing the disease. I encourage you to read the book Encephalitis Lethargica During and After the Epidemic by Joel Walensky. This is an excellent and freely available book. And also, if you can get hold of it, Paul Bernard Foley's book, Encephalitis Lethargica, the Mind and Brain Virus, which really documents excellently the whole history of this, but also the impact on society over the next 20 or 30 years as people were affected by the virus. Includes characters like Cruchet, who probably first described Encephalitis Lethargica, Konstantin von Economo, who had the most famous publication around it, and you know, his name is synonymous with the disease. But they're also lost individuals that we don't really hear about anymore. Felix Stern, who was documenting Encephalitis Lethargica, but also was about to be sent to the concentration camps. And a lot of patients who had this illness, this is one of the reasons to be sent to concentration camps in the late 1930s. And I think it highlights a lot of the stigma and problems of brain disease back then. And we still have these challenges now. Josephine Bicknell-Neal, who's pictured there, was very instrumental in Encephalitis Lethargica in the United States and with the Matheson Commission describing individuals in the 1940s. And Nick Corsellis is just leaping now into the 1960s, was a pathologist who was very interested in psychiatry, mental health, would be in the Runwell Hospital in Essex, have a lab, look at the brains of people who had died, who'd been institutionalized with psychiatric illness, and was seeing encephalitis for the first time in the 1960s, where the cause of the encephalitis was found not to be due to infection, because prior to that time, we had assumed all encephalitis, which really means brain swelling, inflammation in the brain. But to a pathologist, you need to see inflammation in the brain. To a clinician or psychiatrist, we'd say cognitive symptoms, psychiatric symptoms, often with seizures, fever, movement disorder. This constellation of abrupt or subacute, that's the syndrome of encephalitis, but pathologically encephalitis, you see inflammation in the brain. In the 1960s, Nick Corsellis and others saw patients with encephalitis. The first few, they also noticed, or one of them, that the patient had a lung cancer, and they had thought this must be a complete coincidence. How can the lung cancer be related to the encephalitis? But then it became clear that the lung cancer, which is small cell lung cancer, which contains the same kind of tissue that we have in the brain from development from embryos, could trigger an immune response. So this was paraneoplastic encephalitis. And can we go to the next slide, please? Thank you. And this is a video on the left, which is on the neurology website. You can see of individuals who had encephalitis lethargica who have some similarities to NMDA receptor encephalitis. And one of our students, Johnny Tam, who's now a junior doctor in Scotland, we were looking at, could we find the first reports of autoimmune encephalitis? You know, it can't surely have been a disease that's just come about in recent years, with the finding of the NMDA receptor antibody only in 2007. And one hypothesis we had was that Abigail and Betty in the Salem witch trials, if you listen to this podcast in Our Time with Melvin Bragg, and the link is here, there are some very interesting descriptions that have lots of similarities. Of course, this is just a hypothesis and speculation. So we knew in the 60s you could have encephalitis triggered by cancer. In the 1990s, Joseph Dalmau and colleagues in the States, Sloan Kettering, started to find antibodies in the blood that could predict which tumor an individual had. Angela Vincent, with Joseph Dalmau later in the 2000s, started to find antibodies to synaptic proteins that could cause brain illness that we could treat, because prior to 2000, we thought we couldn't really treat these patients. If you remove the tumor, there was pessimism. And before 2000, patients had very strict syndromes. There was encephalitis, there was problems with incoordination, a cerebellar syndrome, for example, and the antibody would predict the disease. From 2000, we saw people with limbic encephalitis, memory changes, profound anterograde amnesia, often with psychosis, often then symptoms that cross between neurology and psychiatry. 2007, with the finding of the NMDA receptor antibody, and NMDA receptor encephalitis was the real game changer, because then the majority of patients would see a psychiatrist first, or they see their primary care physician or emergency department, but they'd have psychosis, behavioral change. It was very difficult to distinguish between someone having a first episode of psychosis and somebody having an inflammatory brain disease, and that's still an issue that we deal with now. So can we go to the next slide, please? And there's been lots of other evidence that, as you know, and I've only summarized this in one slide here, that schizophrenia and psychosis has a role. We think there is a role for the immune system to play. A lot of this evidence, though, is circumstantial. So the neuropathology of schizophrenia, which hasn't been very well studied recently, shows synapse loss, some reduction in brain volume, particularly in the temporal lobes. This has also been seen in CT scanning in the 1970s in schizophrenia, but without gliosis, without scarring. And this is very similar actually to what we see in the NMDA receptor encephalitis. This is coincidental, of course. This doesn't prove that one condition is the other. In the genetic genome-wide association studies, there are genes that have come up that have got immune names, but the caveat there is that we're really just seeing loci in the genes, and we're then choosing the protein next to that loci, and it's already got a name that sounds immunological. That doesn't prove that there's an immune problem. So for example, complement C4 had come up in one of these large studies, but complement we think has which is an immune protein, which is important in lupus and other immune conditions. But we think that complement is also important in the synaptic pruning and development around the time in late teens when individuals can develop their first episode of psychosis. So we have to be wary and interrogate all of these circumstantial bits of evidence and look for real causation. Ketamine, which blocks the NMDA receptor, a very good model of first episode psychosis. And then individuals with autoimmune encephalitis can relapse. Their median onset of age is in the early 20s, lots of similarities there. And one thing we often would point out around 10 years ago when we were looking at this is that the hypothesis wasn't that all schizophrenia is immune and biological, and there isn't an importance for psychological and other factors or developmental factors. But as schizophrenia is such a huge problem, if we were to find that 1% of individuals with schizophrenia had an autoimmune cause that we could treat, then that would be a major impact. And maybe there's more than 1%. Really, to judge if a antibody is pathogenic, we need to see if it can satisfy criteria. Does the antibody affect that protein in vitro, in an experimental setting, and not off-target proteins? We try and avoid animal research, but you can see if the antibody has an effect in animals. A lot of work is now focused on human research. Do patients with the illness have the antibody? and patients without don't. And I think there's a big importance of awareness there of the problem of bias, that if you define a disease by having the antibody, you can start to have circular thinking. If you define everybody who had the antibody as having the disease, and then you go back and say, well, of all the people with the disease who had the antibody, of course you'll see that everybody with the disease had the antibody, because that's how you defined it. So we do need independent ways of determining this. And Tom Pollock has led a consensus criteria for autoimmune psychosis. I forgot to include a slide on that today, but you can see that paper in Lancet Psychiatry. And that complements the autoimmune encephalitis criteria by Grouse and others. Now, we've been seeing patients who satisfy these criteria and do have other diagnoses. You still need to look or treat research criteria with some skepticism if you're doing this as clinical work, but it's very useful for research. So next slide, please. So with Belinda Lennox and colleagues that you'll know, Angela Vincent, Alistair Coles, Peter Jones and others who are still involved with SINAPPS, we started to look actually around 2008 or so at people with early psychosis and see if they had these antibodies. And Belinda Lennox had really been thinking about this for a few years and had been looking at other antibodies. And it was when the 2007 NMDA receptor story came out that we looked at this in more detail. And I was in the lab of, working under the supervision of Professor Alistair Coles, and I was in the lab of Angela Vincent at that time in Oxford, doing part of my PhD. And we had this ballpark figure of around 5% of individuals with early psychosis have an antibody that we think is pathogenic, that satisfies those criteria. Now, later on, we would say that a low NMDA receptor antibody score or a potassium channel antibody on its own are not necessarily pathogenic, and we don't use potassium channel antibody testing anymore. We use LGI1 and Caspar-2 testing. And we now look in the CSF as well more often for clinical diagnosis. But next slide, please. But it's a common finding now, and it's been reproduced many times, that you could find 3 or 4% of populations with acute psychosis, maybe up to 10% have one of these antibodies, but 1 to 3% or so of healthy people have an antibody. So an antibody in blood on its own doesn't make a definite diagnosis. And if we look at some of the individuals that we saw after that first study, we would see people who had a diagnosis of chronic schizophrenia, 3 years illness, hebephrenic schizophrenia with catatonia, with apathy, what looked like refractory schizophrenia, not responding to conventional antipsychotic drugs. But we found an autoantibody at a relatively high level. And actually on investigation involving neurology at that time, meant that we could do an MRI, do a brainwave test, do a lumbar puncture, and we'd see what we thought were unambiguous evidence of inflammation in the brain. So this is somebody who would never have seen a neurologist, who had investigations that showed there was evidence now that there was inflammation. Not only did they have the antibody, but they also had features on their scans and brainwave tests. Now we do know that the majority of people with NMDA receptor antibody illness with encephalitis, even in the intensive care, can have a normal MRI. 1/5 of EEGs are normal. Half of lumbar punctures can be normal. So even these tests are not clear. But with this individual, giving them treatment, they started to respond. So next slide, please. And then we had individuals, and I'll just speed up time, that responded, but nowadays we'd say they had low levels of antibodies and they had no other evidence of treatment. And now we'd say we shouldn't treat individuals like this clinically. We should put individuals like this into a randomized controlled trial, because we may be giving somebody immunotherapy and causing harm. And at the same time, we may be missing a diagnosis of encephalitis if we don't treat. Next slide. And this is just one slide. You can see this report. There are others, that the LGI1 encephalitis presents with facial-brachial dystonic seizures, anterograde amnesia and epilepsy, but can also present with isolated psychosis. Next slide. And if you look at the neuropsychology, we see that NMDA receptor encephalitis often gives you a combination of frontal and temporal lobe abnormalities, dysexecutive syndrome, disinhibition. And the NMDA receptor is expressed throughout the brain, and we don't know why various regions can be affected in some people. It may be due to density of receptor, other receptors, other immune processes, blood-brain barrier and other things. LGI1 encephalitis seems to be a more pure amnestic temporal lobe syndrome with accelerated forgetting, some evidence of spatial and temporal problems with time. And next slide. This is a nice paper from Adam Al-Diwani and Sarosh Irani in Oxford looking at what is psychosis and in NMDA receptor encephalitis. Previously, neurologists would just look for psychiatric features in quotation marks. And this is a nice dissection to show how you can really start to break down the features and look at a large group of patients and see how prevalent various features are. One key message is catatonia and movement disorders like this have emerged. Jonathan Rogers, one of our PhD students at UCL, is studying this and looking at this across the country. And also the overlap. You don't tend to get isolated psychosis or isolated catatonia or isolated affective symptoms. These things can be combined. Next slide, please. So important clinically is to not make the diagnosis just on an antibody. Look for other causes for clinicians. Look for infection. Half of the causes of encephalitis are infection. We have seen NMDA receptor antibodies actually masquerading as NMDA receptor encephalitis. Actually, the diagnosis is CNS infection. Sometimes these illnesses can be triggered by tumors. You need to look for those in a bespoke way. Revisit the diagnosis regularly, particularly if the patient isn't following the expected trajectory. But diagnosis is really improved if you have neurologists, psychiatrists, and others in a room together. And since March, we've been doing this virtually so that you really interrogate all the possible mimics of what's going on. And do involve charities, including, we've heard from Thomas Kabir from the McPin, but also the encephalitis societies. And so next slide, please. And I'll pass on over this slide, but you'll all be aware of this is how we're approaching this. And we now have the SINAPPS 2 study. And next slide. And this is the study from Belinda Lennox and colleagues, the PPIP study, which shows you that you have antibodies in cases, the GABA-A receptor antibodies, another interesting one, but also in few controls. And next slide. And this is another study to show that low levels in both cases and controls, so we need a trial. And the next one. And this is the inclusion criteria of the slide, of the trial, which you all know. And I'll pass this just for time. So if you can carry on. So I'll finally, in the last I think I've got 5 minutes, Giuliano, if that's okay. Or 3 or 4 minutes, talk about COVID neurology. So this has been the major event, of course, for all of us since January and February and March in England, certainly. And this illness, devastating illness of the lungs, we have started to see effects on the brain. So I have just for space and time, I haven't included again a meta-analysis by Jonathan Rogers in Lancet Psychiatry that looks at psychiatric illness with previous coronaviruses, SARS and MERS, in comparison to COVID-19. There's a lot of anxiety that we're seeing in individuals who've had this. It may be too early to determine what proportion will have post-traumatic stress disorder. But in focusing on the neurology and the encephalitis, we have started to see this as well in COVID. Quite, at the moment, relatively rare. And it's something that needs to be looked out for. And there's a nice review in Lancet Neurology by Mark Ellel that's come out this month, and Adil Zubair in JAMA Neurology at the bottom. And we're also part of CoroNerve, which is a national surveillance program here in the UK with Tim Nicholson and the Royal College of Psychiatrists is involved with that. Ben Michael, Tom Solomon in Liverpool in neurology, Rhys Thomas in Newcastle, Ian Galia, Southampton, and neurologists, British Association of Neurologists, paediatricians, British Association Stroke Physicians, in a way to start to now try to start epidemiological study and see who's having these illnesses and can we try and figure out what is due to the virus or not and support further research. So next slide, please. We have reported last week our experience in our MDT. So we had a monthly encephalitis MDT for the last 3 years with infectious diseases doctors, virologists, neurologists, psychiatrists, where we would discuss challenging cases and discuss their diagnosis and treatment. And we found in March, when we thought of stopping the MDT while our fellows were deployed back to the wards and we didn't think that MDT would have much of a role, we found very soon, within a week, that there were lots of patients being referred back, and we had a weekly meeting with an increased number of cases of encephalitis that we would have expected compared to this time last year, including acute disseminated encephalomyelitis, where you see inflammatory lesions in the brain, often with, we think in COVID, there's also probably a mechanism of the immune system being active after COVID, but also perhaps hypoxia, effects on blood vessels. We have seen strokes that have been quite severe, even in individuals who have been already anticoagulated, and we think the virus is causing the blood to thicken up. And we've also seen in a lot of people, maybe up to a quarter of people in some studies from China and Italy, an encephalopathy, a confusional state in individuals who are hospitalized with severe COVID. And some can have psychosis as part of that. This can be very frightening. Thankfully, mostly short-lived, but we need to follow up these individuals to see if there are longer-term problems arising. We've seen peripheral nerve syndromes too. And then the next slide, please, Isobel. So these are some of the brain scans. In COVID, at least, we were seeing people with severe disease, mostly in hospital, but they could sometimes have very minor respiratory illness. And you can see individuals, for example, here at the top, who had the scan that would suggest limbic encephalitis, very similar to the LGI1 encephalitis, but in whom we hadn't seen the LGI1 antibody. And then the other slides are a combination of ADEM, disseminated encephalomyelitis, and also necrotizing encephalitis on the previous slide. And then here we see people with ADEM, one who had a biopsy which supported that, and a feature that's in image M, where you see the splenium of the corpus callosum appears to be affected. And then final slide, this is a panel with stroke that we're seeing, but at the bottom side, one thing that we are starting to see in COVID is microhemorrhages, which may affect vascular fragility and could sometimes be a clue. So those are all my slides. There are a lot of people to thank, and I've got very little time. Certainly Ross, so stop me, Giuliano, when you need to, but Ross Patterson, Rachel Brown were co-first authors on this. Laura Benjamin, Ross Nortley, Sarah Whitehoff, Temi Baruka, who's an infectious diseases doctor working with us. Lots of junior doctors who are involved in this paper. We have infectious diseases support, Anna Checkley, Nikki Longley, neuroradiology with Chandra Sukkar Hoskote and Hans-Rolf Jaeger, Francesco Carletti, and my close colleague, Dr. Hadi Manji. Looking at COVID, I also have mentioned the coroner group. Tony David, Eileen Joyce in psychiatry are very much focused on this kind of work, and also Jerome Breen and others who are looking at the psychological and psychiatric effects of COVID in the long term. So I'll thank you all for your attention. I'm very happy to take questions.
Okay, well, thank you very much, Mike. I am really sorry to everyone in the... Actually, we might have time for just one question. Isobel, sorry, Danielle, over to you.
Brilliant, thank you, Mike. Yeah, we've got a question that's just come through saying, how is the psychosis in COVID-19 patients treated?
Yeah, so we've used, so the first thing to say, we don't have a large experience of this at all. And I think that I would say treat these individuals as you would treat anybody else with psychosis, the standard care of psychosis. So with all the supportive care, all the safety and Mental Health Act requirements that are needed to keep that individual safe, hospitalization where necessary, and the use of antipsychotic drugs if necessary. So the key thing is to have psychiatrists involved and doing this. If there is, if we think there is active inflammation as well, for example, an autoimmune encephalitis, then in a very controlled way, and if we have evidence for that, we would add immune suppression, sometimes with steroids. Of course, steroid-induced psychosis can be a concern. We often try and limit the prednisolone dose to less than 40 milligrams a day. If there isn't evidence of immunity, then just treat the psychosis as before. It was one of the key messages from all the autoimmune encephalitis work that we've done in the last 10 years, and the PPIP study in SINAPPS, was not to stop antipsychotic therapy and just give immune therapy. You need a coordinated approach.
Brilliant. Thanks, Mike. That's great. I think just for time now, unless we have any last minute questions coming in, I'll pass back over to Giuliano just to close up the webinar.
Thank you very much, Danielle, and thank you very much, Mike, for this very interesting presentation. So we've reached today at the end of today's webinar. We would like to thank you all for attending, and we hope you find this interesting and informative. As you can see on the slides that we're sharing, we will have our last webinar on the 21st of July with Professor Peter John, who will give a talk on the neurodevelopmental precursor of psychosis and the relevance to clinical practice. You're all invited to attend, and we hope to see you there. So again, thank you very much for joining us, and enjoy the rest of your day. Thank you.